So, dear Chairman, dear Chairwoman, thank you very much for that nice introduction, and I'm delighted to be at this very impressive meeting in Pune. What I'd like to do is really just over the next few minutes just give you an overview of the ADA EASD Consensus, which we published at the end of 2018 and updated more recently, just a couple of months ago. These are my disclosures. So what I'd like to do is just for the first 5 minutes or so just give you an overview of what we said in 2018, because large parts of that remain the same. But then in the latter part of my talk, I'll just review some of the more recent trials that did precipitate some changes to our consensus. So just to give a brief introduction, I think we've, for many decades, we've managed diabetes in a similar way in terms of, as diabetologists, we focused on hypoglycemia. We've had algorithms that have allowed us to try and achieve a certain A1C target. And so the ADA and the EASD, the Europeans and the Americans, have come together to produce consensus. And this was the first one in 2006, which followed that format. And really, we only had insulin, metformin, and the TZDs. In 2012, that was updated, and you can see metformin was very positioned as the first-line treatment, but then it was very much an algorithm as what next after metformin with the SUs, TZDs, TPP4s, and the GLP-1. So then we had the incretin-based therapies, as well as insulin, and basal insulin was preferred. And the discussion was which combination was used. And even up to 2015, really very little had changed, apart from we then had the SGLT2s then positioned in that what next after metformin. But since 2015, of course, the world has changed very significantly in terms of glucose-lowering therapy, and this FDA requirement for these large cardiovascular outcome trials has given us a huge amount of evidence now in our patients with type 2 diabetes. So when we looked at the 2018 update, we had to do a much more thorough review of the literature. Before, the consensus really was expert opinion, and we didn't feel that was appropriate in this modern world where there is so much evidence now. There is a much greater focus on lifestyle interventions. I don't have time to talk about it very much, but weight loss, bariatric surgery, obesity management, and physical activity are really important, and we've forgotten their importance in the management of type 2. There's a deliberate focus on patient-related issues and self-management in patients with type 2 diabetes, which can have a major impact on any success. We can have the best drugs in the world, but if patients don't take them or don't understand the requirement for them, we will fail. And we also need to consider therapeutic inertia and medication persistence. And I know my colleague from Leicester, Kamlesh Kunti, has been at this meeting also talking about that. But the big difference that we said, I think, was that there are different choices now of different agents depending on the clinical characteristics of the patient sitting in front of you. And we've shifted really the focus on the patient. The person with diabetes should be at the center of their care. And the goal is not to reduce glucose for the sake of reducing glucose, but to really prevent complications and to use therapies that may confer life-changing benefits on patients by reducing the burden of complications. And particularly now we have agents that can reduce the burden of macrovascular disease, and also to optimize patients' quality of life. And that process starts around this decision cycle where you have to assess the characteristics of the person sitting in front of you, particularly with regard to comorbidities, to make those decisions. We also highlighted the importance of empathetic patient-centered care, and that you need to consider the healthcare system that you're working in and the personal, social, and cultural context of the patients that we're treating, and the contribution of the options that we advise in terms of the benefits, harms, and cost, because we live in a world where cost is also very critical. The other aspect is the shared decision-making to inform a management plan, because that can improve the quality of the decisions that we and our patients with diabetes make. And in the modern world, it's an ethical imperative to support patients to make autonomous decisions. We also highlighted the importance of self-management education, because in this world of evidence, actually the evidence of from structured support and self-management programs is as good as the drugs. So it's shown to reduce glycemic control, reduce hospital admissions, improve knowledge, and also there are now meta-analyses showing reductions in all-cause mortality. So the key change, I think, is that this choice of glucose-lowering medications, because remember this is a consensus about the management of hypoglycemia, should be based on patient preference and the presence of established, particularly comorbidities such as established ASCVD, as well as other factors such as hypo, weight, and cost. And so this is the algorithm that you will have seen in the 2018 document, which calls out now not the same algorithm in all patients, but the first priority is to call out those patients with established ASCVD, chronic kidney disease, or heart failure. And I'll focus in the second part of my talk onto how this bit has been influenced by the recent trials. Because remember, when we published this in 2018, we really only had LEADER, EMPA-REG, and a few of the other studies, such as ELIXIR, that are published. In those patients without established ASCVD or chronic kidney disease, there are other factors that need to influence your choice. Is there a compelling need to minimize the risk of hypoglycemia? Is weight gain and losing weight the ultimate priority? And for many people, cost is the thing that makes the biggest decision to their choice or access. So just to concentrate on the new data. So we've had, since we published our data in 2018, a huge amount of new evidence. DECLARE, CREDENCE, Carolina, Pioneer 6, REWIND, VERIFY, and also more data now around the combination of SGLT2s and GLP-1s. And so I'll cover each of these just very, very quickly. So first of all, what about weight loss, and what about the combination of SGLT2s and GLP-1? So as you know, in patients in whom you need to lower A1C, but you're worried or you want to maximize weight loss, then we suggested two classes, the GLP-1s and the SGLT2s. The GLP-1s are quite heterogeneous across the class for weight loss, with the best data with semaglutide and really quite modest data, for example, with lixisenatide. The SGLT2s are more similar than they are different in terms of their impact on weight. But also the discussion, we'd suggested that you could use the combination, although there wasn't a huge amount of evidence to support that. We have data from Duration 8, where the combination of a GLP-1 and SGLT2 was compared to each alone, and there did appear to be some benefit, particularly in terms of added weight loss. And we now have these two trials where, on a background of SGLT2s, GLP-1s were added, either dulaglutide here, where the added value above placebo was about 1 kilogram, and here semaglutide, where there was a greater added value to adding to an SGLT2, and there were a number of different agents in the background therapy of an additional 3.8 kilograms. There's been a recent meta-analysis looking at the combination of GLP-1 and SGLT2, looking at the studies that are available, and you can see this is the impact on A1C, so about a 0.7% reduction, although you can see again there's some heterogeneity. Here's the semaglutide study here, which has the best evidence. And again, with weight loss, about a 1.7 kilogram weight loss across the trials, but again, some heterogeneity with nearly 4 kilograms with the combination. So in terms of A1C and glucose lowering, there is some difference across the class of GLP-1, but we do have across the class good evidence now, or reasonable evidence of this combination, albeit it's a quite expensive combination. What about the SU DPP-4? And I think it's true to say that the DPP-4s, whilst they remain useful, we don't have data in terms of cardiovascular or renal protection. We do now have this data compared with glimepiride and linagliptin showing no difference. Really, I think very reassuring for patients in terms of sulfonylureas not being harmful and being a simile in terms of cardiovascular outcome trial to the DPP-4 inhibitor. And we already know that we get much lower rates of hypoglycemia with the DPP-4 compared to the SU. But I would remind you that the rate of severe hypoglycemia was pretty low in these studies. What about combination, early combination? In our initial consensus, we talked about the need for early combination, particularly in those patients whose A1C was 1.5% above their target. We have this single study now. It's an important trial, 2,000 patients, early diagnosed with relatively well-controlled A1C of this combination with metformin and the DPP-4 inhibitor vildagliptin, showing a reduction in the probability of initial treatment failure. So I think this is an important study, but we don't really know what we would have seen if we used different types of combination, i.e. with a GLP-1 or an SGLT2. But I think certainly in some patients, early combination therapy is looking increasingly attractive. I want to talk a little bit about the recent data with the GLP-1s and the SGLT2s. I'm going to start with the GLP-1 class and remind you that it is highly heterogeneous. So we have the exendin-based molecules, exenatide and lixisenatide. We have the acylated human GLP-1s, liraglutide, semaglutide, and we have the macromolecular GLP-1s, dulaglutide and albiglutide. And we now have certainly the semaglutide and dulaglutide available as weekly formulations, and as you know, semaglutide also available in the US now as an oral formulation. So we start with quite different agents, and then we have 8 trials of the GLP-1s which are all quite different. So if you look at the size of the study, so you have the very large trials such as Excel and then Rewind, which again in 10,000 patients. We have the small studies like Sustain 6 or Pioneer 6, which is the smallest trial of oral semaglutide. There are differences in the A1C inclusion. So when we made our initial consensus, all of the outcome studies had inclusion criteria of people with A1Cs above 6.5 or 7. So it's very difficult to make a recommendation that you should start independent of A1C, whereas now in Rewind there was no lower limit, and in fact many patients had A1Cs down to 5.5%, and the median A1C was only 7.2. Also, the inclusion criteria vary hugely. You have some studies in which all of the patients had established disease and were very high risk, like Elixir, where all patients had had an acute event, contrasting with Rewind, where only about 30% of patients had established disease, although there is some subtlety to this, because a significant proportion here, the so-called subclinical group, were similar to patients that would have got into, for example, the LEADER trial. So this is not so straightforward, and at the time we did our update, and indeed still now, we don't have a breakdown for these 3 different subgroups. They're just either all lumped together or all lumped in this group as the people without disease. So if we look at the outcomes, we can see that there are differences. So we have 4 studies that show a positive result, and 4, the one is not on here, Freedom, which has had a press release which showed it was neutral. That's the implantable exenatide. And this isn't simply, it may be due to a number of factors. It may be due to a definite difference between the GLP-1 agent itself, it may be different in trial design, or it may be different in the cohorts of patients included. And if you look in ELIXIR, which was adequately powered and was a very high-risk group, there was really no impact on the MACE endpoint, although it was a 4-point MACE, but there was no impact on 3-point MACE. Whereas if you look in, for example, SUSTAIN-6, which was actually an underpowered trial, there was a significant reduction in 3-point MACE. And there does seem to be some advantage of either the acylated or macromolecular GLP-1s in consistency in showing a reduction in 3-point MACE. In some of the studies, we see a reduction in cardiovascular death in LEADER, and in fact, although there's no p-value here because the study was small and underpowered, there was nearly a halving of cardiovascular death with the oral semaglutide. No impact on heart failure, apart from in HARMONY, where there was a slight reduction in heart failure outcomes, but across the class, no impact. And as you see in both REWIND and SUSTAIN, some reduction in stroke. REWIND is important because if you look at the outcome by baseline cardiovascular disease, as you know, overall, this was a 12% reduction. There didn't appear to be a difference in people with a history or of not or cardiovascular disease, although if you look in prior event, and these are people with MI or stroke, although the p-values not for interaction isn't significant, there is a greater reduction in those patients with MI or stroke compared to those without. So I think there's still some debate about the risk factor profile and how far we should open up the prevention with GLP-1s based on this evidence. In terms of kidney outcomes, the GLP-1s clearly have shown a reduction in proteinuria, and there was in REWIND a reduction in the composite kidney endpoint, but it was largely driven by, again, the impact on macroalbuminuria, and we've seen that also with SUSTAIN and with LEADER. So GLP-1s, reasonably good for the kidney, they're licensed to low eGFRs, they reduce proteinuria, but they don't have the same impact as the SGLT2s have. So just some comments about the SGLT2s, and I think we're learning all the time, so we know now from this meta-analysis, if you look at across the SGLT2s, across people with existing cardiovascular disease, we see this 14% reduction. There's a little bit of difference within the agents, but across the class it seems to be relatively consistent. But nothing, no harm, but no reduction in MACE in people without established cardiovascular disease. And that's where the evidence sits at the moment with the SGLT2s. However, when we come to heart failure, I think, as we've just heard in the previous session, a lot of excitement around the SGLT2 class, consistency as secondary outcomes in these big studies for reductions in heart failure. If we look across the class of glucose, different classes of glucose-lowering therapies, we now have evidence to help us make very clear choices. We have benefit with the SGLT2s. We have safety and neutrality with the alpha-glucosidase inhibitors and the GLP-1s. We have heterogeneity in the DPP-4s, with some showing no signal and others showing an increase. And we have, we shouldn't use the TZDs, obviously, in this setting as they increase the risk of heart failure. We also have DAPA-HF, and in the brilliant talks just before me, you saw some of the data, and we know that in reduced ejection fraction heart failure, even in people without diabetes, we're seeing reductions in cardiovascular, in primary endpoints for heart failure in these patients. And there will be, I'm sure, a license change to support that. In terms of renal disease, we get reductions significantly in terms of dialysis, end-stage kidney disease, and reductions in acute kidney injury with the SGLT2. So I think very, very clear evidence now in terms of heart failure and chronic kidney disease. So what changes have we made? Well, the first thing we've said, which I think is a significant impact, is that we should be using these agents independent of baseline A1C or individualized targets. So we shouldn't wait for the A1C to be out of control. We should be adding GLP-1s or SGLT2s to reduce MACE, heart failure, or chronic kidney disease progression, regardless of the baseline A1C. In terms of the early combination, we didn't feel on the basis of one study we could change that, but there may be shared decision-making around early combination use, and we already advocate it in people more than 1.5% above target. What about the GLP-1s? Now, as I think I've shown you, or hopefully convinced you, the data for MACE appears to be stronger for the GLP-1s than it is for the SGLT2s. And so where the level of MACE is the greatest threat, then they are probably preferred for that reason, although there may be other reasons around costs and injectable therapy why you may choose differently. But in terms of MACE, that's where the GLP-1s have the strongest data. And also, we've now suggested that they should be considered in people without established disease, but with high-risk indicators. And it's difficult because in the previous talk, I think they talked about younger type 2, and I am very passionate about aggressively treating young type 2. In all of these studies, less than 1% of patients were under the age of 40, and many of those patients were excluded from these trials. But now we should consider high-risk indicators for also their use. The SGLT2s in people with or without established atherosclerotic disease, but with particularly reduced ejection fraction, heart failure, or chronic kidney disease, and we talk about an albumin-creatinine ratio of greater than 30, but particularly greater than 300, we have very good evidence now for the benefit of the SGLT2s, particularly with Credence and others. So we are recommending their use in those groups of patients. The foot ulcer story we need to be careful about, shared decision-making. In Credence, where there was good surveillance of those patients, then we didn't see the increased risk of amputation. So this is how the algorithm looks now. It talks about those high-risk indicators. It talks about heart failure. And right at the top then, it talks about adding independent of A1C and the preference for the GLP-1s for MACE, but you can obviously still use an SGLT2, and the clear preference for the SGLT2s in the setting of heart failure or chronic kidney disease. Thank you for your attention.
Thank you, Dr. Melanie. Any questions or comments?